What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast. Illuminating the darkness of current EMS clinical practice with the bright light of science. Here are your hosts, Dr. Jeff Jarvis and Mike Verkest.
Hey everybody, welcome to the EMS Lighthouse Project podcast. Mike Verkest, Dr. Jeff Jarvis back with you again. This time, guess what, Dr. Jarvis? It's our first video podcast.
Oh my God. You mean
I know.
People can see me?
They can. They will see your every move and they're secretly judging you.
Well, hell, I would have dressed up. I'm sitting here wearing my KUT t-shirt.
Well, in all fairness, you actually did dress up, but we did some artistic lighting things, and we just discovered you just need to change your clothes.
It's true. I did have to get my my NPR plug-in for my local Austin station.
Exactly.
Oh, good
So
time.
so welcome to episode 34. This one is going to be another great one, as you can imagine, and we've got a pretty action-packed show for you. We're going to have a great interview with Dave Wampler, and we're going to have just like almost we asked for feedback, and people gave us some feedback on the last one we did with Dr. Aaron Lincoln, with where we sort of involved the oral board sort of case study, and people seem to really enjoy that.
They did. And so I believe we need to, like the Kink said, give the people what they want.
Exactly. So that's exactly what we're doing here on episode 34. And so we've got another oral board sort of case study that we will be doing, and we will introduce you to that special guest as we get going a little bit further. But we're going to talk about some stroke stuff, large vessel occlusion. And I'm pretty excited about it because, number one, I love the fact that, and you'll learn this about Dave here in just a couple of minutes, but he's that paramedic turned PhD, which we know there's a few of those out there, right?
Yeah, quite a few. And
it's so awesome. They do such amazing work, and I cannot tell you what value to EMS do these guys and gals provide. It's just so amazing, right?
Absolutely.
Yeah.
I can think of quite a few. I mean, just right off the top of my head, there's Dr. Wampler, Dr. Emily Kidd, Catherine Counts, some amazing people out there. Bill Legio, who's now here in Austin, some great folks.
It just really helps us all as we sort of progress into this evidence-based world that we, at least many, claim to be involved in. And so we're actually gonna get involved in that. So but anyway, so what's new with you? I know there was a couple of things you want to talk about before we actually get into the interview with Dr. Wampler. And one of them is about a medic of yours from Williamson County. Do you want to take a couple minutes and talk about that?
Yeah, I sure do. So one of our medics recently died unexpectedly. So Lisa Dalton was one of our field training officers. She's been with us for quite a while. Her husband also works with us, Jamie Dalton. Jamie and Lisa have been with Williamson County for quite a while, and are clearly part of our family. And our hearts are absolutely breaking. It's just really hard to think about what life is going to be like without Lisa in our system. So if Jamie is watching, I just want you to know how much we care about you. Lisa was an amazing woman, incredibly compassionate and caring, always friendly, and a great teacher to our students. So it really was a huge loss to our system. So thank you for bringing that up, Mike.
Yeah. And you have a really relative small family there, right? About what, 130, 140,
Yep, we're a tight-knit group.
Yeah, God, that's just heartbreaking. So sure sorry to hear about that with Lisa, and lots of prayers and thoughts for Jamie and the whole family. It's just got to be super tough.
I appreciate that. there are a couple of other things that I want to hit on.
Yeah.
One, I want to plug another podcast. So
what?
I know we
So
don't
great.
often do that.
It's a great podcast. No, that's not true. If it's good, we want to tell you about it because it's not about us, right?
Well, that's true.
Yeah.
So let's hit this one. ACEP, the American College of Emergency Physicians, has one of the, I wouldn't say one of the premier journal in emergency medicine, Annals of Emergency Medicine. It has been there for a long time. They just released a new journal called JCEP, the Journal of the American College of Emergency Physicians, Open. Henry Wang, our buddy Dr. Henry Wang, is the editor-in-chief, and this is an open access journal. Well, this journal has a podcast to accompany it where it goes over the literature of each episode. And Dr. Matt Delaney and I are swapping out podcast hosting duties.
Hey, you're cheating on me.
I am cheating on you, Mike. I am so sorry. JCEP is a good cause. And what the hell are you talking about? You cheat on me with Ritu.
Yeah, that's true. That's true.
Actually, you're probably cheating on Ritu with me. But we'll let that go.
Yeah, I'm moonlighting with you for sure.
Well, listen, the episode we just recorded is all about COVID. So August has 10 papers all about COVID. We review all of them in about 25, 30 minutes, so you don't have to read them all. And I shouldn't say that because you really should read them. They're great papers. Speaking of COVID, we're going to have a new episode. Our next episode, what's it going to be about, Mike?
Well, it's not going to be a lighthouse, and it's not going to be a second shift. It's going to be, again, a thrown together mega mix of both Dr. Ritu Sani, Dr. Jeff Jarvis, myself, and maybe a special guest. We're kicking it around. We don't really know. But this is going to be a live episode on Facebook, Twitter, Instagram, Twitch, YouTube, wherever it is you want to watch, you can be able to find us. So look for a little bit of information coming out about that. And what's the topic going to be?
Well, you know, we decided we're going to tackle the elephant in the room. There is so much, frankly, Dr. Toon, I'm sorry. I know he doesn't like it when we cuss, but so much bullshit out there in the ether, so much pseudoscience crap. We're going to take on the big one. We're going to talk hydroxychloroquine.
Yes,
we're
we
going
are.
to do it not in what I believe or what you believe, but what the literature says. That's what we're going to take on with our next podcast.
I love that. And it's going to be great. So that'll be a live discussion where you can join the conversation. And we look very much forward to you jumping in and submitting questions and what your thoughts about hydroxychloroquine. But let's get back to episode 34.
Absolutely.
I'm super excited. We're going to talk about stroke.
Yes.
But we're going to talk about a specific kind of stroke, and we're going to talk about stroke scales.
Yeah.
And it's a very interesting topic. And so it turns out one of our good buddies making his second appearance, and I confirm that, by the way.
Good.
On the EMS Lighthouse Project podcast is Dr. Dave Wampler.
Yeah. So Dave is a great guy. Started off as a paramedic. He's down in San Antonio, which seems like a world away to me, but it's just right in my backyard. Dave has done a great deal of research, but he's also talked to us about his research in the past. He is going to take us through a paper that he and his colleagues at San Antonio Fire and Acadian Ambulance did when they introduced the VAN score. And that is a test for large vessel occlusion. So Dr. Wampler is going to run us through the paper. And then what we're really excited about is we have another special guest star that we will introduce. I'm going to leave it hanging. We'll introduce her when we come back after talking to Dr. Wampler.
I love it. So you guys enjoy this quick, about 15 minutes or so interview with Dr. Wampler and Dr. Jarvis, and we will talk to you in just a few minutes. All right. We'll see you then. Dr.
Wampler, welcome back to the podcast.
It's great to be back.
It is so good to have you. I'm not sure. I might have to go back and look at the archives of the EMS Lighthouse Project, but I think you may be our first return visitor.
Really? That's awesome.
Not really a visitor, but anyway, I can't think of, if you are our first, I can't think of a better person to have back twice.
Very exciting.
Dave, do me a favor. Just give us a rehash of where you work, how a nice paramedic ended up as a PhD researcher in San Antonio.
Well, I grew up as a paramedic in Kerrville Fire Department. I worked there for about a decade while I was finishing my undergrad, and then I went to the great state of Utah to get my PhD in biochemistry. And I came back and decided I didn't like teaching chemistry as much as I liked EMS. And so I began working at UT Health Science Center in San Antonio and in the Department of Emergency Health Sciences. And my current role is I am the Director of Clinical Research for the Office of the Medical Director for San Antonio Fire Department.
Outstanding. So one of the things that really helps you with, you do a lot of research and you end up on a lot of research papers.
Yes.
That is a pretty cush gig if you are trying to build a CV.
Well, it's a lot of work too. I actually have to do some stuff to make that happen.
Absolutely. I mean, you don't get on papers for not doing anything.
That's true.
And it is also a pretty cush gig if you actually really enjoy doing research, doing reading and writing and doing analysis.
You can just call me a nerd. That's fine.
That's oh, that's so funny. There's a reason I like you. What was the name of that? We did a lecture called Revenge of the Nerds, didn't we?
We did, and we're going to do it again.
We are. It's going to be virtual this year.
It will be virtual EMS Expo, and I'm so disappointed that EMS Expo is only going to be virtual because it was going to be in Vegas on my birthday.
Oh my God.
I am so disappointed.
Your liver, on the other hand, is doing backflips.
That's true. But, just think, the American Heart Association says wine is very good for your heart.
They say scotch and bourbon are good for your heart too.
Yeah, they're not the American Liver Society.
One more thing. You are on Twitter. What is your Twitter handle so everybody can follow you?
I am David Wampler 17.
David Wampler 17. Everybody, he is a good follow. Do that. So since you do research, you are on a paper that we want to talk about. The title of that paper is Paramedic Utilization of Vision Aphasia Neglect, or VAN, Stroke Severity Scale in the Pre-Hospital Setting Predicts Emergent Large Vessel Occlusion Stroke.
Yes.
You have quite a few of your colleagues. I certainly know some of them. We're going to have Dr. Kidd on in our next segment to do a clinical case, and it looks like Dr. Miramontes was the senior author on this paper. Who was the lead author? I don't think I know them.
Lee Birnbaum. He is our local interventional neurology neurosurgeon.
Well, so we're going to get into the meat of this paper, but why don't we start off by just giving us the background? Why is this an important topic to study?
So historically, San Antonio anyways, has used the Cincinnati Stroke Scale to determine whether or not we're going to call a stroke alert. Between the Cincinnati Stroke Scale, time to last known well time, and normal glucose, relatively normal glucose. If all of those parameters are met, then our medics can call a stroke alert. But that's just a yes or no. That's not a big stroke, little stroke. That's just stroke. And as we all know, the analogy I always use is trauma. There's a very different thing between a broken radius ulna fracture and a gunshot wound to the chest. Minor trauma can go to the closest facility typically. Major trauma needs to go to a trauma center. Cincinnati Stroke Scale identifies strokes in general. If we can identify those major strokes, we can get them to a major stroke center, and the less major strokes we can get to a primary stroke center, or most of our facilities can handle smaller strokes. Large strokes need to go to a comprehensive stroke center where they can do the interventional procedures to be able to go up in there and do the thrombectomy.
What would you do differently if you have a VAN positive stroke?
So it's really trying to get the right patient to the right facility. If a patient is VAN positive, they need to go to a facility that has capabilities to do the interventional procedures. Patients that have the small vessel occlusion, they need to go to a closer facility to get the medication treatment in a more timely fashion. So we don't want to delay care by bypassing some hospital that can manage a smaller stroke. At the same time, we don't want to delay care by inappropriately transporting a large vessel occlusion to a primary stroke center when they need to be at a comprehensive stroke center.
So what was your clinical question in this paper?
The question we were asking was, does the VAN score perform as well as the NIH stroke scale greater than 6 in predicting either large vessel occlusion or a intracranial hemorrhage?
Two questions there, right? One is, does it perform as well as the NIH in predicting LVOs by themselves? And then a subsequent question was, does it perform as well as NIH greater than 6 on a composite endpoint of either large vessel occlusion or intercerebral hemorrhage? Did I get that right?
Correct. Because either one of those probably needs a comprehensive stroke center anyways.
Good. And I think that's an important point. I remember looking at this, and initially I'm like, why are you doing the composite endpoint? And the reason is this is designed for the field, and the whole question we're asking is, should we take this person to the closer primary or divert to a slightly further away comprehensive?
All right, we're trying to drive decisions with this, with the result of the VAN score.
I like it. So what was the population you studied here?
So so this is 2 EMS systems within San Antonio and Bexar County: San Antonio Fire Department EMS and Acadian Ambulance. San Antonio Fire Department is the 911 provider for the incorporated area of San Antonio. Acadian, they cover all of the unincorporated components of Bexar County outside of San Antonio and several of the other small metropolitan cities within this area. That was sort of our setting. The specific population was, we were looking at all patients where EMS called a stroke alert.
Okay. And is this adults only or children also?
We did not limit it to children, but we did not get any children during the time period.
Fair enough. All right. So what was your intervention?
The intervention was any patient that was a stroke alert, the paramedic that was treating them during transport also performed a VAN score, VAN assessment, sorry. And if they identified this as a VAN positive, that was included in the report that went to the receiving facility.
Now, you mentioned that the intervention was doing the VAN score, and then you talked a little bit about training. Can you give us an idea how you trained on this? Is this something that you have to go to school for a month and a half to learn?
No, we did our training was 2 ways. We did it live for as many of the medics as we could get during the 2-week period that we were doing the live training. It was about an hour. It took about 30 minutes to teach the components, and it took a few minutes to do some practice VAN assessments, and then there was a test at the end. Then for all those medics that couldn't get to the live one, we had a brain shark that actually went through, used the online training materials, and they got to go in and actually do some practice testing, and they had to, select whether or not this was a VAN positive patient, and then they ended up with a test at the end as well.
Very good. So it sounds like the training on it was relatively concise. It didn't take a whole lot of time.
No, it was about an hour per class.
So just going through the PICO question here, we hit population and intervention. Did you have any controls here?
It was a prospective observational study. We were comparing the VAN score with the NIH stroke scale that was performed in the emergency department by either the emergency physician or the neurologist that was accepting the patient.
Very good. So what was the date range that you were including in this study?
We looked at 18 months worth of data from June 1st, 2017 through December of 2019.
What was the outcome that you were calculating?
Our outcome was the performance of the VAN score as compared to the Nih Stroke Scale greater than 6.
And what were you measuring when you defined performance?
We were defining that by the sensitivity, specificity, positive and negative predictive values, and the overall accuracy of each of the components on their own, and then sort of put them into a 2x2 comparison table, dichotomizing them into yes or no. So that's sort of categorical data that we can fit into our chi-square table.
The one thing I seem to remember from my biostats class in grad school is that anything worth knowing can be summarized in a 2x2 table.
If you can make it fit a 2x2 table, it makes life so much easier, and it makes, people that are not statisticians like myself, it makes it so I can actually run the statistics.
Exactly. I like it. Do you mind if we run over just real quickly what sensitivity, specificity, positive and negative predictive value are?
Yep. So sensitivity is, can my test actually detect the disease? Specificity is, how often does a true test indicate that the patient actually has disease? Positive predictive value is the likelihood that a positive test, the patient actually has a disease. And negative predictive value is the likelihood that a patient that tested negative does not have the disease. And accuracy is sort of the combination of those two.
Perfect. And we will put up in the show notes the 2x2 table with the descriptions and definitions of all of these. There are sort of notorious tables. These are one of the things that I always have to go back and reference. I have my favorite little table, and it summarizes all of this for us. So thank you for that quick description, Dave. What did y'all find?
So when we looked at just the VAN score being able to predict large vessel occlusion, it was almost as good as the Nih Stroke Scale greater than 6. Not quite. But if we included large vessel occlusion and intracerebral hemorrhage together as one composite group, the VAN score was equivalent to Nih Stroke Scale greater than 6. That's important because both large vessel occlusion and intracerebral hemorrhage still should be triaged past the local facility to go to a comprehensive stroke center. So if we're looking at trying to get the right patient to the right place, I don't care if it's a large vessel occlusion or if it's an ICH. If it's either one of those, they need to go to a comprehensive stroke center.
Fair enough. Fair enough. And what was your overall conclusion?
The VAN score was equivalent in being able to detect large vessel occlusion or intracerebral hemorrhage to the Nih Stroke Scale greater than 6. For just trying to predict a large vessel occlusion, it wasn't quite as good. But if you look at it, even an Nih Stroke Scale greater than 6 is only about 68% accurate in predicting these things. So our VAN score, if we're just looking at a way to be able to get the right patient to the right facility, I think it's performing as good as any of the other tests. And the VAN score is easy to teach, and it's easy to perform in the field and doesn't take a lot of time that's going to be delaying getting your patient moving towards the hospital.
Very good. Thank you very much for joining us and going over that paper. I think this is a great contribution to our literature on how to identify these patients with LVOs. I'm going to include a link to the paper, and then I'll also include an abstract in our show notes, as well as that sensitivity specificity table that we talked about. Thank you so much. Have a great day.
Thank you too.
As always, great interview. Love hearing from Dave. So insightful, good stuff. But, we'll talk a little bit about what we got going on here in Portland here in a minute. And it has nothing to do with federal buildings or anything like that.
Thank God.
Yeah, I know, right? But but let's talk about stroke scales in general. And you have I really wanted to steal your line. And we had a little discussion about that, but I think there is common thought probably across the country about stroke scales. So lay it on me, Dr. Jarvis.
You bet. So I was actually trying to choose for our primary stroke scale between LA and Cincinnati.
Yes.
And so I went to the literature because that's the kind of guy I am. And Jane Bryce, Dr. Bryce, had a wonderful paper that compared the two. And my takeaway when I read that has not changed when I start looking at VAN scores or LAM scores or race scores or any of the others. And that is that all stroke scales suck. Some suck a little less than others. And if you have a stroke scale that's gonna suck, since you got to use one, you may as well use the one that sucks a little less and that is easy to use.
Yeah, I think that right there is the key. And I'll tell you, it really nails it on the head, because one of the things that, because I come from a training perspective, right? So when all you fancy doctors come up with this brilliant idea, I'm the one that has to go out. Well, just take this for what it's worth. We have to somehow translate that and get those people trained up in the field, right? To be able to take that thought process, the why, understanding what is the goal we're trying to do here, whether it's destination, whether it's specificity, sensitivity, whatever it's going to be, and translate that to sort of our bell curve of paramedics that are out there, right? And so that's always a challenge. So I think you're spot on. Is you have to take the one that sucks the least, the one that's the easiest to use, that you can reproduce those results on, and from a system perspective, be able to really apply that and make sure we're doing the best we can for our patients.
Absolutely, man. And I think VAN does that. And I will tell you, when I am in the emergency department, I have to use the NIH stroke scale. Mm-hmm. But the truth is, when EMS comes in with a stroke alert, just like in a case we might be hearing about shortly, when they do that, I meet them on the stretcher in the hallway. I don't have time to do a full NIH stroke scale.
Yeah.
What do? I do a Cincinnati and I do a VAN, and then they're on their way to the CAT scan. So I think it is easy, it's rapid, and it allows us a first approximation on, is this a stroke? And if it's a stroke, is this a large vessel occlusion? That way I have a decent framework and I have some information to help guide my treatment decisions. Because when you're in an emergency department or in the field and you have a lot of decisions to make all at once, in the ER, I'm probably managing 10 different patients. I'm giving orders on those. I'm trying to think what I'm going to do to Mrs. Smith or with Mrs. Smith in bed 5. It helps me if I have some sort of pre-pathways programmed into my brain. And if we have a patient who is VAN positive, my pathway now is going to include some extra steps. So for me, those extra steps are likely get thrombolytics going, if that's a possibility, and then arrange for transport. If it's VAN negative, then I'm not so worried about that.
Yeah, I like that a lot. So let's talk about this next segment here. Now, again, we kind of teased about this a little bit in the intro, but people seem to really like the idea of a case study, of an oral board. And so, again, like Rush says, or no, who is it? Who wants to give the people what they want? It wasn't Rush.
Oh, that's the Kinks. So, Mike, I understand y'all are not big McMullen fans in Portland. You don't like the Cincinnati scale. You want to use your own. What is this Portland thing that is probably easing out of the federal building that I understand is kind of being protected right now?
Yeah. We got people. We've got people for that. So we've gone through, as I'm sure most other people that are listening, whether you're a medical director, a field provider, whatever it is, we've kind of ran the gamut, so to speak, on stroke scales, right? So we start off with LA pre-hospital stroke scale, the modified one, of course, and that was fine for a while. Or maybe we started with Cincinnati. We started with Cincinnati, went to LA, and guess what? We were finding patients that would slip through the cracks. Now, per protocol, our crews were on the ball enough that you're not going to let a 26-year-old that's presenting with aphasia, like that's probably a stroke until otherwise proven it's not, right? So using some of these other stroke scales, those are the patients that we could potentially miss. And again, I'm talking about the bell curve of providers you've got, right? You've got the middle, you've got the left, and you've got the right. And so you have to make sure whatever your protocols are, your guidelines, your training, you're sort of meeting everybody where they're at. So what we found was that the Cincinnati, the LA, those were sort of leaving a little bit of a hole. So what we did was we took the LA and then we added aphasia to it, because currently that's not part of the LA stroke screen. And so once we did that, we couldn't call it the LA, we couldn't call it the Cincinnati. So guess what it is? It is the Portland pre-hospital stroke screen. Is it validated? Hell no. Of course not. But
why not?
Currently when we sort of made it up, if you will, and I'm using air quotes, I guess we're on video now, I can do that.
Validated.
Yeah,
so you derived.
So we derived this idea that, you know what, this makes sense for us. And so that's been in the protocols now for about 2 years. And so we're getting to the point where we should be able to start collecting some data and going backwards and looking at this to see if we've actually captured some of those people. And that is absolutely a plan for us, at least in our area here. And I'm looking forward to finding out what those results are. And for us, you know, we use CSTAT. So we use Portland Pre-Hospital along with CSTAT. We talked about CSTAT, you did in the interview. And for us, CSTAT seems to work pretty well. And for us, it really drives our destination, just like you talked about in the interview there with Dave. And so if somebody presents itself with a positive stroke scale and a positive CSTAT, then that determines our destination. So we're going to go to right? So we're going to a comprehensive stroke center if we have that CSTAT positive, right? So we've got to have both of those. But let me ask you this. This is something that I have struggled with since comprehensive stroke centers came out. And I know the answer, and I don't like the answer, but I'm curious what your thoughts are going to be on it. And that is, if you have facilities in your area that have the plaque on the wall, the stamp of approval, we are a comprehensive stroke center. We can take care of this patient from the time they walk through the ED doors to the time they get released to wherever it is they're going to go. I feel like, and in our area, it's pretty, every hospital is a stroke center of some kind, but we have 3 comprehensive stroke centers that happen to be the same as our trauma centers. So we bypass multiple hospitals with trauma entries. And so my question is, why don't we bypass community stroke centers to go to comprehensive with all of them? It's only a few more minutes down the road. And the answer I typically get, I don't like. I understand it. I don't like it. I don't think it fits in with the values that I have for our patient. I think they should get the highest level of care and treatment possible. And if that means you drive 5 more minutes down the road to get to or 7 minutes or 8 minutes, 10 minutes, whatever, I think they should go to a comprehensive. I think every stroke, just like every trauma, goes to a specialty center.
Yeah. So here's the problem with that.
I know the problems with it. That's just my heart. That's what I feel like. Yeah. But
let me lead off by saying, Mike, you ignorant slut.
I know, clearly.
So yeah, the challenge with that, one, is that you are delaying care some extent. And when you're talking about stroke, if you buy into the benefit of thrombolysis, time is brain. If you buy that notion, then those extra minutes are delaying the ability to give TPA. So going to a primary stroke center that is capable of rapidly getting the imaging and giving TPA probably is the right thing to do, rather than delaying that care to get to a comprehensive. Because as you pointed out, comprehensive centers are also trauma centers. They're also STEMI centers. They're also sepsis centers. They're also, trimal right ankle fracture centers of excellence.
Right.
And all patients are coming there. And the problem is, when there was a great paper that looked at the impact on mortality of other patients when a trauma alert comes in. So when these things come in, if everything is an alert, then nothing is an alert. And that's the problem. You get just saturated. It's like alarm fatigue. The other issue is the majority of strokes don't come into hospitals by ambulance.
That's
they
true.
walk in.
I would agree with that.
Or, maybe drag themselves in.
Right.
And if we are taking all strokes to the comprehensive centers, the primary strokes who still have to deal with all of these walk-ins aren't very good at it anymore because we're diverting patients away. So I think the time benefit is really the right thing to do. The other issue is that maybe it's not a stroke at all. There are some mimics, and I realize this is a shock, but we miss some of those mimics.
No,
we miss them in the emergency department, and I miss them in EMS, and I miss them in the emergency department. So sometimes that is the right thing to do.
Yeah, I mean, I guess it's not that I don't buy it. I mean, I understand that, but I don't. Yeah, I guess you're right.
Well, let me give you another argument here. More care is not equal to better care. There is paper after paper that shows that patients who are highly demanding and end up getting more care, a great example of that is physicians treating their physician colleagues. They feel obligated to do more. They do more, except the outcomes are actually worse. So more care, I do more tests, patient outcomes are worse. So more care is not better. And if you take every stroke patient to a comprehensive center, you are likely to get more endovascular therapy. And as you ramp these numbers up, eventually, even if it is a small percent of patients who get endovascular therapy when they wouldn't benefit and have an adverse outcome, those numbers are going to rack up. So just keep that in mind when we're dealing with any intervention. More care doesn't equal better care.
Yeah, you know what, and I really appreciate your explanation of that, because I will tend to have sort of this pie in the sky view of what do I think is what in like, and I do a lot of it with my heart. That's kind of, and it's not a problem, but it does create a bit of a, when we're talking about research and science, you kind of have to go with kind of, what does the research say? So I appreciate that. And I understand that a little bit more now, but in my mind, it was like, in order to be a comprehensive, you've got to have numbers. So you have to be able to do enough of these to be good at it, and so on and so forth. And so in my mind, it's like, well, if that's the place to go, we should just go there. There's also a financial piece. Like, let's not lie, right? Let's talk about that. If you think that the community hospital that's got their CT scanner, they're ready to go, if you don't think they've invested money in that piece, they don't want to lose out on those patients, which in their minds are completely appropriate. That jives exactly with what you were saying. We can give TPA. We've got the scanner. We can do all this stuff right here. And if they need to go later, we can always drip and ship or do whatever the local system sort of dictates.
Absolutely. So let me talk about drip and ship.
Yeah.
I see this a lot, that medics will take a stroke to a primary stroke center and they'll say, yep, it's a stroke. We did the scan, completely normal scan, push the TPA, start the drip, and off they go, and they transfer them out. And the medics
are like, why didn't we just go here in the first place? I don't know.
I failed. No, you did not fail. A hub and spoke system, a drip and ship system, is absolutely appropriate. It is good treatment. Now, the other thing we do is we frequently will think patients are always better in the academic tertiary care center than they are in the local community hospital. That is not true. If you look at the literature on outcomes from level 1 versus level 2 trauma centers, outcomes are actually a little bit better in level 2 trauma centers. The bottom line, though, is if everybody is uber specialized and all patients go past the community hospitals to the uber specialized center, it doesn't take long in our jacked up healthcare system that we strangle the local community hospitals, and those local community hospitals get less and less patients. They get less and less experience. They get worse and worse. And guess what? Now they're not there. Yeah. And now you don't have a choice. Your sprained ankle, your sore throat, I think I have COVID, all of that shit has to go downtown.
Yeah.
And you have deprived the community of an incredibly valuable resource. So
Yeah.
there is absolutely a double-edged sword to these uber specialized tertiary care referral centers when you cut out the outside hospitals. Go to the outside hospitals. It's okay. That's what the emergency department is there for. We do our triage. We initially stabilize them. And then if we have to transfer, it's okay. We transfer them. Now, that is not to say that there are not some patients that do benefit from taking that extra step and going directly to the specialty center. Now, and there are some stroke patients that might benefit. So, Mike, why don't we do this? Why don't we think about this in terms of a case?
I like that idea.
You want to talk about a case?
Let's do it.
I got a great idea. Let's bring in a special guest.
Okay.
Dr. Lincoln kicked our inaugural case, oral board case, out of the park.
Great job.
Big boots to fill. Great big Texas-sized boots to fill. I can't think of anybody else to come in for round 2 than Dr. Emily Kidd. Emily is a friend of mine, is an outstanding emergency physician and EMS physician right here in Texas. We're going to do a case with Dr. Kidd on a stroke. Shall we kick it off and hear what Dr. Kidd has to say?
Let's do it. All right, let's move on to that next segment, and we will talk to you after Dr. Kidd and Jeff get done wrapping. All right, talk to you soon.
Well, Dr. Kidd, thank you very much for joining us.
Absolutely. Thanks for having me. I'm glad to be here.
So, y'all, Dr. Kidd is a unique person in EMS. She is, she actually has my favorite grouping of characteristics. She is an Aggie. She is a former medic. She is an ER doc and an EMS physician. And most importantly, she's a Texan.
That's right. As are you, all of those things as well.
That's right. I think this is the reason I like you. We were talking offline about not wanting to make things too Texas centric. And I said, well, I think this is an audio podcast. So what people can learn about us is from our voices. And I think there's not going to be a whole lot of question about where we're from.
That's right.
Well, Dr. Kidd, right now you are, as I mentioned, you're board certified in emergency medicine and in EMS. And you are I want to make sure I get the title direct. I've been saying Texas Medical Director for Acadian Ambulance. Did I get that correct?
Yes, that's correct. I'm the Texas Medical Director for Acadian Ambulance. We're in 4 states, and so I am responsible for medical direction in the state of Texas.
So I want to ask you just a few questions about that, and just because that's intriguing. You have multiple locations. Do you have the same protocols for everybody, or are they different? How does that work?
In general, yes. We have kind of a core set of protocols that we utilize throughout the entire company. We're in Texas, Louisiana, Mississippi, and Tennessee. In Texas, as you well know, we are very regionalized because Texas is so big, has so much geography and different issues in different areas of the state. Regionalization through our RACs or our regional advisory councils is very, very critical. And so in Texas, we modify our protocols to some degree, depending on which region we're in or which RAC we're in. For example, in the San Antonio, South Texas STRAC region, we modify how we transport our STEMIs, our strokes, our trauma based on the guidelines that we as a region, all the hospitals and EMS agencies in the region have decided on. And so I would say that as far as our protocols for Acadian, that would be the modification for us in Texas is, by region.
Sure. Makes perfect sense. And just from my buddy Joseph Zalkin, I have to get this in because otherwise he's going to drink himself to death waiting to get buzzword bingo. It's easy in Texas because we're a delegated practice state.
That's correct. That's absolutely correct. And it is definitely a blessing to be able to have delegated practice.
Yes, it is. It is. Well, speaking of delegated practice, why don't we hop right in? We're going to do a case. And just like we did with Dr. Lincoln in our last episode, we're going to run through a case. And since this episode is about stroke, it's not going to be a great surprise that this case is going to be about stroke. So most of our cases when we do our oral boards, start off with a chief complaint as the patient pops up on the board. This one's going to be a little bit different because it's going to start with a radio report, and I'll give the radio report, and then we will transition to the patient magically arrives in your emergency department, and we take over from there. Sound fair?
That sounds good.
University Hospital, this is Jeff on Medic 11. We're en route to your location with a stroke alert. This is a 72-year-old fully functional female without prior stroke history. Her stroke screen is positive for right arm and right leg paralysis as well as aphasia. Her last known well was 5 hours ago. She denies any trauma and has no anticoagulation use. Her blood pressure is 190 over 100. Heart rate is 92 and a sinus rhythm. Respirations are 18. Pulse ox on room air is 99%. Her glucose is 108, and her 12 lead is non-diagnostic. We are obtaining a second IV access now, and we should be at your location in 10 minutes.
Excellent. We will see you upon arrival. Please notify us if there are any changes en route.
Will do. See you soon. All right. So with that, we're going to fast forward. Let's just go over some of the things that you might be thinking about in the 10 minutes, because of course, this is the only patient you're taking care of right now.
Of course, there's no COVID patients in the ER at all to manage.
That's right. That's right. So what kind of things are you thinking about?
All right. Well, so the first thing is I'm going to have our hospital activate a stroke alert, which will clear the CT scan, make sure we have all of the ancillary folks in the ED that we need, and we'll activate the neurologist, neurointerventionalist to be able to consult when the time comes. As I'm listening to my radio report, I'm thinking several things. Obviously, the first thing I'm concerned about is an ischemic stroke. With an ischemic stroke, things I'm concerned about is this patient a TPA for IV thrombolysis, a candidate for IV thrombolysis? So what does that mean? Is she, number one, is she within the time window, which would be 4.5 hours or less? In this case, what they're telling me is that it's been 5 hours since her last known well time. So automatically, I'm thinking she may not be a candidate for TPA. I want to know, is she going to be a candidate for a mechanical thrombectomy? Does she have an LVO? And what I'm being told right now, with the aphasia and with the right arm and right leg significant weakness, is she may very well be a candidate for mechanical thrombectomy. Also, I'm worried about the potential for a hemorrhagic stroke. They told me no trauma. That's always something we consider. They told me that she's not on anticoagulants, which also would be a question that I would ask had they not volunteered that. She is very hypertensive right now, so that's something that we're going to have to think about getting under control fairly quickly. I also worry about other things that are stroke mimics, such space-occupying lesion, hypoglycemia, which they did check a blood sugar. It's very important to check in the pre-hospital setting to make sure your patient's not hypoglycemic, because we know that that's a big stroke mimicker. Other things would be a neurologic migraine, some sort of toxicology emergency, a TIA potentially, or a seizure.
All right. Well, the patient has arrived and you meet them as they're coming into the emergency department. What would you like to see or do next?
All right. So as we are going to the CT on the EMS stretcher, I'm going to be doing a quick assessment of the patient's mental status. Is she awake, alert, and oriented?
She is.
Okay.
She's making good eye contact and answering your questions.
All right. I'm going to do a quick assessment of the ABCs. Is she stable, maintaining her airway, good circulatory, no circulatory compromise?
Correct.
Okay. And I'm going to be doing my own initial rapid neuro exam. So we've talked about her mental status. We're going to do a quick Cincinnati or FAST exam, look for facial droop, arm drift or pronator drift, and any slurring of speech. Does she have any of that?
She does not slur her speech. She has no facial droop, but she is unable to perform the pronator drift with her right arm. Left arm stays extended against gravity with no difficulties.
Okay, so that would be a positive on the Cincinnati stroke exam. So then my choice for an LVO exam is the
Okay.
VAN exam. So I'm going to be quickly asking her if she's noticed any vision changes.
She has not.
Okay. I'm going to do a quick visual exam on her. Does she have a vision forced gaze to one side or the other?
No, she is looking directly at you,
Okay.
and she
Uh,
tracks you as you move left and right.
okay. Does she have peripheral vision on both sides?
She does.
Okay. All right. You already mentioned that she has aphasia, which is the A part of VAN. When you say aphasia, is it expressive or receptive? Is she able to say words? Does she say the correct words, or is she not able to speak at all?
How would you test that?
So the first thing, I'm already talking with her to determine if she's able to speak with me and use appropriate words. I would also at some point show her my watch or a pen and ask her to name the word. And how she responds to that tells me if she is receiving what I'm saying and understanding the language, and to be able to determine if she is able to say the correct word or if she has an aphasia.
Perfect. So when you tell her to do things, she does them. For example, you tell her to raise her arms. She is clearly trying to do it. She does it with her left arm. She's trying with her right. She's trying to get that shoulder action in there to lift it up and cheat. But so she is understanding these things. And when she talks to you, she is speaking clearly. There's no slurring, but she does seem to be getting frustrated because she'll pause like she's trying to find words. You point to your
Okay.
watch and she can't come up with a word. You ask her if she
Okay.
knows what that is, and she shakes her head. Yes, she understands what it is, but she can't find the word for it.
Okay, so I would say that that's definitely a positive already. We don't even really need to go on to the end part of neglect, but we will. And so, does she show me any signs of ignoring one side of the body or the other? You tell me that she's not able to move her arm. Does she show recognition of the arm? Can she feel me touching it, or if I show her arm, does she understand what she's looking at?
Yes. So when you check for sensation, sensation is there. And she definitely acknowledges people on both sides of her and recognizes that there is an arm there.
Okay.
She
Okay.
definitely seems frustrated that it's not working.
Okay. So at this point, she is positive for her Cincinnati and stroke scale, and she is also positive for VAN. So what that tells me is I'm now concerned that she's got an emergent large vessel occlusion or an LVO. While we're going to this, she's going to go directly to the CT scanner because, like I said, we're going to be evaluating for intracranial hemorrhage.
All right, so the patient is off to the CT scanner in the emergency department. The patient's nurse went with her to take care of her there. In the meantime, EMS introduces you to the patient's husband, who can give you additional information about her.
Okay. Hi, sir. My name is Dr. Kidd, and your wife right now is getting a CAT scan of her head. While she's doing that, I'd like to ask you a couple of questions about her medical history, if that's okay.
Yes, ma'am.
Okay. Can you tell me, does she have any medical history? Does she take any regular medications for anything? And if so, what?
She does. She has high blood pressure that she takes lisinopril for, and she has high cholesterol that she takes simvastatin for, but no other medical
Okay.
problems, and she doesn't take any other medications.
Okay. And some of the other things that I'm wanting to know about, other than the hypertension, would be: does she have a history of migraines? Does she have a history of seizures? Does she have diabetes? Has she ever had a hypoglycemic episode before?
She doesn't have any of those.
Okay. I would also ask, has she ever had a history of a stroke?
No, ma'am, she hasn't.
Okay. Has she ever had a history of a tumor in her head or in her GI tract or a GI bleeding?
No problems with bleeding, and she's never had anything in her brain.
Okay, and she's never had a bleeding disorder for any that's ever been found? Okay. And again, I'm asking all of these things, should she potentially be a candidate for TBA, which she is not, but these are things that we need to be thinking about and
You bet.
asking. Okay. Does she smoke, drink alcohol, or use any illicit drugs?
She'll have a glass of wine every once in a while. She doesn't smoke, and she doesn't use any other drugs.
Okay. And any allergies to any medications? Any recent surgeries?
No, the only surgery she's ever had was a cholecystectomy, and that was 20 years ago.
Okay. So now I'm going to basically wait to hear back from the radiologist to see what her CT scan shows.
Hi, Dr. Kidd. This is Dr. Jarvis. I'm the radiologist. I just read your CT scan and looks good. I don't see any gross bleeding, no differentiation, gray white matter. Looks like a completely normal CT scan.
Okay.
You hang up the phone and only to hear it ring again. And Dr. Kidd, I am Dr. Jarvis too, and I'm the I am the stroke doctor. I understand you have a stroke alert. What you got?
Hi, Dr. Jarvis, too. Nice to talk to you. I have a 72-year-old female with a history of hypertension who just came in by EMS emergently. She had onset of right arm and leg weakness as well as expressive aphasia. Unfortunately, her last known well time was 5 hours ago, so she is out of the time window for TPA. No history of trauma. She's not on any anticoagulants. She is a little hypertensive at this point. Her blood pressure is 190 over 100. Her blood sugar is okay at 108. She just came back from CT and has no evidence of hemorrhage on her CT scan. She is positive for her Van scale and with the aphasia.
Okay. All right. So I understand 72-year-old female, 5 hours ago was her last known well. She has a positive stroke scale with right-sided deficits as well as aphasia. I agree with you based on the last known well. She's not a candidate for TPA, and certainly sounds like she could be a candidate here for intervention. Let me go ahead and do my telemedicine consult with her. In the meantime, if you don't mind getting her prepped for a CTA, an angiogram, so we can take a look at her vasculature.
Absolutely.
And in the meantime, also, what were you thinking about for blood pressure control?
Well, for her blood pressure, I would like to bring her blood pressure down a little bit. Obviously, we want it to be under 180 over 105. And so some of the options that we might have might be labetalol or nicardipine or hydralazine. I would probably start her on nicardipine infusion, started at 5 milligrams an hour and titrate. We don't want to bring the blood pressure down too fast, but we definitely need to get it down to below where it is.
Yeah, nicardipine sounds great. Let's go ahead and get the CTA ready, and I will talk to her, and then I'll give you a call back when we get the results of the CTA, let you know what we're thinking. All right. So let's just fast forward here to the next phone call. So you are off seeing your 13 COVID patients, and the phone rings. You have started a nicardipine drip. Her blood pressure is now, let's call it 155 over 90. No other changes, and she's had no change in her clinical presentation. Hi, Dr. Kidd. This is Dr. Jarvis too again, and I agree with you. I think after my exam, she is not a candidate for TPA because of the time window, but I do think she might benefit from intervention. The CTA you showed certainly looks like there's an occlusion of her left middle cerebral artery. We'll go ahead. The cath lab team should be on their way down, and we'll get her off and we'll take care of her. Thank you very much for your help.
Great. Thank you. I appreciate it.
All right. So that is the end of the case. Let's talk about it just a little bit here, Dr. Kidd. So we talk about blood pressure control. Why don't we just have paramedics drop her blood pressure? We're really good at that. We used to use nifedipine all the time, Procardia. Just a little squirt of Procardia, and it was great at lowering blood pressure. We could also use nitroglycerin. It'll rapidly lower that blood pressure. Why don't we want to do that for these patients?
We do need to get the blood pressure lowered to improve our outcomes. However, we know that lowering it too fast or too low can affect the penumbra and further traumatize the already traumatized brain. We want to try and lower the blood pressure, the systolic, between about 150 and 180 initially. We don't want it to drop below about 130 to 140 once the alteplase is given. So it's really important that we in the pre-hospital setting, we know that some of the medications and some of the administration can actually drop that blood pressure too low and too fast. And so that is the reason that most EMS agencies will not actively lower blood pressure, even for stroke patients in the pre-hospital setting.
Sounds good. I remember I was a medic in the Procardia days. And when you actually look at the literature on that, it says, yeah, you'll lower their blood pressure for patients who aren't having a stroke. And congratulations there, Slick. You just gave them a stroke.
That's correct.
All right. So that's, I think you did a great job on that case. And I think it brings up some really important concepts. And I'd like to talk to you a little bit more about those in the context of your job as a regional medical director. You mentioned something earlier when we were offline about how important dealing with things like stroke is, about dealing with it on a regional and a systematic basis. What was your meaning about that?
So when we're talking about stroke systems, we all know that there are, support stroke centers, primary stroke centers, comprehensive stroke centers, and thrombectomy ready stroke centers. And we just want to make sure that EMS agencies and hospitals are all on the same page in the region about which patients are going to be brought to what hospital under what circumstances. So some very robust regions may have multiple comprehensive centers spread out throughout the region, and somebody who meets a positive LVO score, it may be easy to transport that patient directly to the comprehensive center. Others may have only one or two, or they may be clustered into one area. And it's important for everybody to be on the same page about at what point are we going to take that stroke patient past the primary stroke center into the comprehensive stroke center. Right now, what the guidelines say is that if there's a difference of 15 minutes or less between primary stroke center transport and comprehensive stroke center transport, it's probably best to take someone with a positive LVO score to the comprehensive center. They also say that if somebody is now not TPA eligible, whether they're outside the window for whatever reason, to consider transporting directly to the comprehensive stroke center as well. But it's really important that as a region, everybody understands what the capabilities are of each hospital, what the capabilities are of the EMS agency, and that the EMS agencies are all following similar guidelines for care and transport of those patients.
Dr. Kidd, in the emergency department, we go over our stroke scales, the NIH stroke scale. Why don't we just use that in the field?
Well, the NIH stroke scale is a great tool, but it's a tool to be used in the emergency department. It takes a little while to do. It requires calculation of the score with multiple different pieces of the scale. And it also requires the determination of severity, which can be very subjective. So for a pre-hospital scale, number one, the providers need to have something that's easy to use, in my opinion, that doesn't require calculation, that doesn't rely on a subjective determination of severity, and that is easy to teach. And I particularly like the VAN for that reason. It doesn't require a calculation. It doesn't require subjectivity. You look at three things, and either the answer is yes or no. And if the answer is yes, then it's a positive scale.
You bring up VAN. Let's go ahead and go over that. What are the components of it?
So the components of VAN are, number one, you have to have a positive arm drift or pronator drift on your Cincinnati Stroke Scale.
Okay.
Look for motor deficit. If that is positive, then we go to the VAN portion of the scale, which stands for vision, aphasia, and neglect, looking at cortical symptoms.
Okay. So what would constitute a visual defect?
A visual defect would be somebody who has a gaze deficit or has an hemianopsia, a deficit on one side or the other, or a deficit in peripheral vision.
Okay. You mentioned hemianopsia. Do they have a visual field cut? So is there some piece of their 360-degree vision, if you will, that they can't see? Are they not able to see the right side or the left side out of either eye?
Correct.
Okay.
Correct.
Now, aphasia. What is aphasia?
Aphasia, it's a difficulty in understanding or producing language. And so you can have a receptive aphasia, you can have an expressive aphasia, you can have a range of aphasia anywhere from not understanding what somebody is saying to you, not understanding the words, to being unable to say an appropriate word, as we were talking about earlier with showing a patient an object and asking them to name it, all the way up to the point of being unable to speak at all or make any language.
Very.
So anywhere along that range would be positive.
So one thing that I find gets confusing a lot is a lot of people will confuse dysphagia with aphasia and slurred speech. So, for example, they will try to use the patient has slurred speech, which is really a motor function. Their lips aren't moving, their tongue's not moving. The motor functions responsible for speech aren't working, and they'll call that aphasia. And that's not what we're looking for here.
Right. And I think it's important to remember that that is part of the initial Cincinnati or FAST exam.
Yeah, bingo. Okay, so that's aphasia. They're either not able to find the words or they're not able to understand the words. Good. What about neglect? What is neglect?
Neglect is basically the patient ignoring one side of the body or the other. And so the way that you determine that is you touch both sides of the body. You determine, can the patient feel the touch or the sensation on one side of the body? Is the patient able to move one side of the body? And sometimes in extreme cases, the patient may not even recognize one side of their body as belonging to them. You may hold their hand up and ask, whose hand is this? And they would say, oh, well, that's your hand. And so it's just basically a lack of sensation, motor, or recognition of one side of the body.
So neglect, those patients that I've seen, it is really fascinating to see. It's a horrible thing for the patient, but intellectually it is really interesting. So there was a neurologist, a very famous neurologist, who wrote a book in 1985. His name is Oliver Sacks. And he wrote a book called, the title of it is The Man Who Mistook His Wife for a Hat. And he just tells these stories of these bizarre neurologic deficits and how they present. The last patient I had with neglect, she could recognize me and talk to me if I was standing on her right. She had no idea I was there when I was on her left. It's a devastating deficit, but it's really interesting. So why don't we go over briefly what the eligibility criteria are for TPA, and then what the eligibility criteria, broadly speaking, is for endovascular therapy or EVT, what we're talking about with retrieval or catheter-based lysis.
Okay. So eligibility for TPA, we're all probably fairly familiar with that by now because we've been doing Cincinnati Stroke Scale and looking at TPA eligibility for many years in the pre-hospital and emergency medicine setting. So we know eligibility is age greater than 18 years, onset of symptoms less than 4.5 hours prior to arrival at the emergency or administration of the TPA, and then clinical diagnosis of an ischemic stroke without evidence of hemorrhage on the CT scanner. Patients need to have no history of ischemic stroke or a severe head trauma in the last 3 months, previous intracranial hemorrhage, previous GI hemorrhage within the last 21 days, GI malignancy, intracranial malignancy, or any recent spinal surgery within the past 3 months. Also, we don't want to obviously give TPA to someone who has a hemorrhage or a subarachnoid hemorrhage or a patient that you have a high suspicion of subarachnoid. As we discussed earlier, we want to make sure that the blood pressure is not extremely elevated. It needs to be below 180 over 105. There should be no evidence of active internal bleeding, aortic dissection, obviously. And then we also need to consider, is the patient on anticoagulants? What is their platelet count? And as I said, no evidence of hemorrhage on the CT scan or any extensive evidence of hypodensity consistent with a devastating or very large stroke.
Once we have determined TPA eligibility or the lack thereof, what types of things are our neurology colleagues going to be looking for to determine whether to take a patient for endovascular therapy?
Right. So I think obviously the first thing would be, does the patient have signs and symptoms consistent with a large vessel occlusion, as we were just discussing earlier? If the patient was able to have a CT angiogram, is there evidence of an occlusion on that CTA? Are the symptoms onset within 24 hours? So we have a little bit larger time window with mechanical thrombectomy than we do with TPA. And then finally, does the patient have anything else going on that would preclude them having the procedure? Do they have a DNR? Do they have other significant comorbidities that would either prevent them from having such a procedure, or if the procedure were done, it wouldn't really make much difference in their outcome? I think those are the things that we need to be looking at broadly.
Yeah, I think that makes sense. And there's an analogy here to, say, our cardiologist when they're trying to determine whether to take a patient to the cath lab for a STEMI. So there are some patients, we had one yesterday, clear STEMI, but they also have baseline dementia. They don't know where they are. Their functional capacity isn't going to be improved by this procedure. So yeah, I think that makes perfect sense. Well, Emily, thank you so much for joining us. I think this was a great episode. I think we got a lot of good stuff covered. Strokes, I mean, we see these all the time, and they can be absolutely devastating to our patients. And now with the onset of thrombectomy, I think we have the ability to really do some good things for our patients.
Absolutely, both from the emergency medicine and the pre-hospital medicine side.
Absolutely. Well, thank you very much, and I hope that you have a wonderful COVID-free day.
Thank you. Appreciate it. You too.
Take care.
All right. As always, Dr. Jarvis, tremendous job walking Dr. Kidd through that case. And again, I love the oral board. I love the oral case just because, even on the paramedic side, forget the doctor side. It's awesome. Well, you don't have to forget it, but it really makes you think about every single thing about that patient, right? And you just don't have the verbal cues. Like when you do a scenario where you've got your kits and you've got the monitor and you've got a gurney, you are automatically clued into these things need to get done. Like I turn around, oh yeah, okay, we'll get transporting right now, whatever. You don't have any of that. And so you really have to have things straight in your mind and know how you want to carry out those orders, know the sort of your differentials, the things that are going to be required for that patient. And so, man, I just love them. So great job on that as always.
Well, thank you. And I think the format really works for what we're trying to do here. One of the things we're trying to approach is not just what you do, but what you think. What is your thought process?
Right.
And we've looked at a couple of different ways to try to bring that out. And I don't know that there's anything better than an oral board presentation, because the way that we are taught to do these in residency is we want to make sure that our examiner, who is sitting across from a table in a weird ass hotel room, what we want them to know is what we're thinking, and we want to just verbalize our differential diagnosis and how we're going to make the determination of what bubbles to the top of our differential and why we're ordering certain tests.
Yeah.
But we can't actually say that. And so that's the skill that goes into these oral boards. And I think it's a great way to actually communicate what we're thinking. And as Ginger, talks about all the time, what's going into the mindset of your clinical decision making. So I love it. In this case, I think Dr. Kidd did an amazing job. I've known Emily for quite a while. She is an absolute rock star. So it is not a surprise to me that she did well on this.
Of course. It's awesome. All right. So let's talk about thrombolytics. So I guess you've kind of convinced me that, maybe these community hospitals, these stroke readies, probably fine, right? Because they're going to give thrombolytics.
They have a role.
Yeah, they absolutely have a role. I just feel like if the comprehensive 5 minutes away, you should just go there. Anyway, I'm not going to get hung up on that. But let's talk about the medication itself. So TPA, for example.
Yeah.
What's the next best, greatest TPA thing? I mean, is that what it is? Is that as good as it gets? Is there something new coming? What's the story with that?
That's pretty much it, baby. So interestingly, if you go back, the corollary everybody looks at with thrombolytics for stroke is thrombolytics for STEMI. And we
Yeah.
looked at a lot. And by the way, if you compare the effectiveness of lytics for stroke with the effectiveness of lytics for STEMI, there is no comparison. The literature is overwhelming that lytics work in STEMI. The literature is definitely debatable in the impact of lytics for stroke. So I think there are, especially some evidence-based medicine purists will tell you that there are some problems with the papers that were positive for lytics. And they have to do with some really nerdly things about baseline differences. And let's just not get into that. But
Yeah.
bottom line, let's go on the assumption that lytics work. We have not found that there is any new, better, greater, faster, sleeker, sexier lytic coming down the pipeline. A lytic is a lytic when it comes to this. So we're probably not, we have seen, I think, the maximum benefit that we're going to get from lytics. There are some better things coming down the pike. Endovascular therapy deals with widgets. It's a procedure. And it is highly likely that we're going to have better widgets, smaller widgets, more maneuverable widgets. Perhaps we're going to be able to get access to smaller and smaller vessels. Wouldn't that be great?
Yeah.
No evidence that that is the case now, but it certainly could be. So I think we are about tapped out in the maximum benefit we're going to get from lytics. But when we started seeing papers like Mr. Clean and the others that there's a real benefit to endovascular therapy, I think we're going to see continued progression when it comes to endovascular therapy. So I'm actually really excited about that. The big question, though, is from an EMS standpoint, can we identify the patients who are going to benefit from endovascular therapy, and what is the best way to do that?
Yep, exactly. And again, what's it going to be? Is it going to be VAN? Is it going to be CSTAT? Is it going to, I don't know. And I guess that brings me to my kind of my final thought is I feel like you need to do what's best for your particular system, right? And we talk about rip off and duplicate R&D stuff all the time, but what might work in Portland is not going to work in Williamson County. And if there's something better is not even the right word. If there's something different that works for your system and your hospitals and the whole systems of care, I think that's where the money's at. That's what you do, what works for your system.
Absolutely. And, you know, Mike, one of the things, just to compress this podcast into a certain amount of time, I had to do some editing on my discussion with Dr. Kidd. And one of the things that we had to cut out was her discussion of the importance of systems of care and the impact that these diversion decisions can have on smaller systems. So if you're saying take everybody to the uber specialized center that just happens to be downtown, well, if you're already downtown, big whoopee, no worries, not a big impact. But if you are a system that has 2 ambulances and it's a 45-minute transport and let's say a 2.5-hour turnaround time, that's a big impact. So you really do have to consider this in a systematic way, and that's really important. And I'm sorry that we had to cut that part from Dr. Kidd's discussions because I think she did a great job of summarizing that.
Yeah, and I think there's something to be said for you know, the HEMS industry in stroke, right? So that what you were just talking about, is there some benefit to a helicopter evacuation of that stroke patient that is a 50-minute transport? It's taking 1 ambulance out of the system for 4 hours to go and do. I don't know. I don't know what the answer is, but I feel like that's probably true.
I think you're probably right. And that is a really important point, because when you're talking about helicopter EMS, what we always look at is it's sexy and it's clearly faster than ground all the time, every time, except when it's not. And when you actually look at the data, there are a lot of cases, particularly in the suburbs like you and I work in, where it's not faster. And what we overlook is that the risks inherent to HEMS, we skip over. There are clearly patients that will benefit from HEMS.
No question.
And there are clearly patients that won't. And I think the big issue when we're dealing with stroke is we need a better tool than we have now. VAN, I think, is probably the best that's out there. But hopefully with continued research, we're actually going to get even better tools that are going to help us differentiate when should I call the helicopter versus when should we go in by ground. And like we were talking about, that's going to differ from system to system.
Yeah, exactly. All right. Any final thoughts before we get up and out of here?
So yes, Mike, thank you so much. So there are two things that I want to do. Number one, I again want to thank Drs. Wampler and Kidd for their gracious gift of their time and expertise. I loved these interviews. So thank you so much for that. If y'all are enjoying these interviews, please let us know. We appreciate that feedback, and it helps us guide the podcast to go. The next thing that I want to do right as we leave is let you know that we are all going batshit crazy in our COVID lockdowns. Even if you've eased the lockdown just a little bit in your state, I'm looking at you, Texas. Even if you've eased it a little bit and maybe you're pulling the reins back, all of us are going stir crazy and we need some diversions.
Yeah.
My recommendation to you is the diversion that I have found that I really like. And that is a television remake of one of my favorite movies of all time. And that is John Cusack in High Fidelity. So Hulu did a remake of that movie, and it's based on a Nick Hornsby book, which I just finally had to break down and buy. So I'm looking forward to reading that. Hulu has that movie redone as a TV series starring Zoe Kravitz. And someday on another podcast, I'll tell you the tie-in between the Cusack movie and the Zoe Kravitz character. So that's my recommendation. What's yours, Mike?
No, I love that. And that will be an amazing. Do people even know about John Cusack and High Fidelity? I've never seen it. So I'm sorry to offend you, my brother. I love you.
Oh my God.
Don't. It's okay.
Dude, you, my friend, have an assignment.
Okay. Speaking of assignments,
I want to know when you watch it.
Okay.
Could you sell that album by Beta Band? Would you buy the Beta Band album?
Okay. I will let you know. So it is super important. And I know everyone hears this all the time during COVID, non-COVID times, back in the old days. That's prior to January. But, taking care of yourself and finding ways to kind of get through this, super important, right? So if you're struggling, definitely reach out, talk to somebody. You could literally contact Dr. Jarvis or myself. If you've got nobody else, we're happy to talk to you. Lots of resources out there to make sure that you stay safe, you stay sane during this. Just, it's an exhausting time right now. And I think you said that perfectly the other day. But so one of the things I've done, I've always been doing Fire Dog Productions for a while, do podcast editing, voiceover, all that stuff. But I've really started trying to take my photography a little bit more serious. So I'm starting to, I bought a new lens, and I'm going to go out and play around with that a little bit. And I've decided to go back to school, get my bachelor's degree. So I am starting in the fall in EMS management with Eastern Oregon University. I am a mountaineer now, Dr. Jarvis, a mountaineer.
Mikey, I am so happy for you. That is awesome.
Yeah.
Congratulations, man.
Thank you. Yeah, it's going to be good. And there's a lot of anxiety right now, which I mean, it's more excitement and nervousness about I've already done this once, managing full-time job, flight bridge ed, family, whatever. We'll get through it, but I'm looking forward to the challenge. And I've already registered for my first 2 classes in the fall, September 24th. Let's rock and roll, baby.
Do it.
Yeah. All right. Well, I will get us out of here. So on behalf of Dr. Jeff Jarvis, Mike Verkest, you've been watching the EMS Lighthouse Project podcast, watching or listening, depending on what you got going on. We appreciate everything that you do, all the support that you give, the feedback, the emails, the tweets. It is awesome. You can find me at Mike Verkest on Twitter. And Dr. Jarvis, where can they find you?
At Dr. Jeff Jarvis on Twitter.
All right. We are a proud member of the Flight Bridge Ed Podcast Network and
a Fire Dog production.
And we will talk to you on the next EMS Lighthouse project. You guys take care, and we will talk to you soon.
Take care, y'all.
Bye.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the Flight Bridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.